and the National Institute of Public Health. And we provide expert commentary later on the session. We are honored to have Dr. Ngocho Burial, environmental and public health expert. So without further ado, we turn our attention to the experience from Liberia. So please join me in welcoming our first speakers, Mr. Solomon. Mr. Solomon, if you hear, the floor is yours.
Good afternoon, everyone. Am I loud enough? Hello. Good afternoon, everyone. Am I loud enough?
Yeah,
Can I go ahead?
uh, wait a minute so I can share your screen.
Okay. Good afternoon. Are we still sharing the stream?
Yeah, but I am trying to share your screen.
Can you just put it on slideshow, please?
Could you make it at the slideshow, please, Eva? Yeah, you
Are
can
we
go
putting
ahead.
on? So, good afternoon, colleagues. My name is Solomon K. Japa Jr. I work for the National Public Health Institute of Liberia, where I serve as an event-based surveillance analyst in the Division of Infectious Disease and Epidemiology. Currently, I serve as the Mpox lead, the Mpox focal person for the Mpox response here in Liberia. So this presentation basically is just an overview of the Mpox situation since we had the outbreak declared in last year, August. I will just run us through what we've been up to, what have been some of our response strategies since the response started in August. Next slide, please. So this is just the outline. Next slide, please. The previous one. Okay. So I will give us a little bit of a profile of the country, and then we talk about the levels of the health system or the health system in general, how our health system here in Liberia is structured. So Liberia is a country located in West Africa. We're being bordered by Sierra Leone, Guinea, Ivory Coast, and that of the Atlantic Ocean. As far back as 2024, when the last census was conducted, we recorded about 5.4 million people in the country. Our country is divided into 15 counties, or we call them 15 sub-political divisions. Of that divisions of 15 counties, we have 5 health regions, 98 health districts, 848 health facilities across the country. Now, the way our health system is structured, we have 5 levels of the health system here in Liberia. It starts from the community. Sorry. It starts from the level of the community. From the community level, we have the facility, which is the next level immediately after the community. After the facility, we have our district level. From the district, the county, and that of the national level. Now, the reporting flow goes through these levels. It might either start from the national level and filter down to that of the community level, which is the least level, and it could also start from the level of the community, and the report goes up to the national level. So these are the levels of the health system in Liberia, and each of these levels we have personnel at each of the levels, health workers at each of the levels that work within the health sector and report directly to the immediate level that supervises until it reaches the national level. Next slide, please. Okay, so for the import situation in Liberia, we have 21 priority diseases, conditions, and events that we keep surveillance on. Hello, am I loud enough? Hello.
Yes, we can hear you. Yeah.
Yes, we can hear you. Go ahead.
Hello.
Hello, Mr.
Are you
Solomon.
getting me?
Yeah, yeah. Go ahead.
Am I loud enough?
Yes, we hear
Yeah,
you
yeah.
clearly, loud and clear.
The previous slide, please. The previous slide. Yeah. So as I was saying earlier, we have 21 priority diseases, conditions, and even in Liberia that are all immediately reportable. Mpox happens to be one of them. Now, the Mpox situation in Liberia started as far back as 2016, where we have sporadic cases that were reported across the country up to 2022. Now, for the current outbreak that we are currently responding to, our first case was recorded in August 31st, 2024. That first case was recorded. Now, that first case was a 7-year-old female that was reported in one of our counties called Sando County. And that case shows symptoms on the 20th of August 2024. The case visited the facility on the 24th, and it wasn't until the 31st that that case was tested and confirmed positive of Mpox. So this is like the origin of how the current outbreak that we are responding to started. Next slide, please. Now, since the 1st of January 2024 to present, this is the country's dashboard for Mpox. Since 2024 of January 1st up to yesterday, the 27th of November, we have recorded a total of 2,656. Hello?
Yeah, yeah. We heard you.
Am I loud enough?
Yes, yes. Your voice is very clear. Go ahead.
Okay. So as I was saying, since the 1st of January 2024, we have recorded a total of 2,656 suspected cases. Of that number, 2,505 have been received at the lab. We have issue with sample transport, and most of the time, all of our suspected cases, samples are now collected from them. Hence, the decline in the total number suspected and that of the number that have been received by the lab. Of that number received by the lab, all of them have been tested. And till date, we have had 1,444 total confirmed mpox cases in the country. Now, currently, we have 56 active cases, out of which currently we have 56 active mpox cases. That means that 1,384 have recovered. Today, we have only recorded 6 deaths of mpox in country. Further down, you'll see the distribution across the various counties. We have recorded, like I said earlier, we have 15 counties in Liberia. We have recorded cases in all of the 15 counties, and we see the breakdown there for male and that of the female. We seeing that the male are accounting for more of the cases recorded so far. So this is just like the country's dashboard showing all of the basic information on total suspected cases, total cases tested, and then confirmed active cases recovered and the deaths that have recorded so far in country. Next slide. So this is just an epic curve showing us the trend of the outbreak from epic week 1 of last year to this year. We're still on the previous slide, but this, yeah, so from the data collected so far, we've seen cases being recorded in the adult population, more cases being recorded in the adult population. Uh, yeah, more cases being recorded in the adult population above 18 years is where we see more of the cases recorded. Even though cases have been recorded across all of the different age range, but more of the cases have been recorded in the adult population. We yet to understand why. Studies are on the way to understand why we've had more cases recorded in the adult population. Next slide. Next slide, please.
I think we lost Hiba. I will try to fix it.
Mohammed, are you there?
Yeah, yeah, I'm here. I think we lost Hiba. She was sure. I will try to share screen by myself. Dr. Ahmed, are you there?
Restore lei.
Okay. Hiba, could you share your screen?
Sharing now. في حد تاني مش عامل شيرنج، اطلعوا كلكم. في حد تاني.
دي انا دي
وانت انا بطلع. عمل ستوب شيرنج. خشي.
دي رقم.
So we're on the previous slide. Yeah, we're on the previous slide. So the next after this.
Could you close your camera on, Hiba?
We're on the slide after this.
Okay.
This okay, this I can go ahead now, right?
Yeah, you can go ahead.
No, the previous slide. The previous slide, please. Hello, the previous slide, please.
What title of slide?
The first slide on the activation of the IMS. The first slide on the activation of the IMS. Yes, this one.
You can go
The
ahead,
slide
Doctor.
on the activation of the incident management system, please. Okay, so far, since the outbreak was declared, we activated the yeah. So far, since the outbreak was declared, we activated the incident management system. Under the incident management system, these are the pillars that were incorporated. We have the coordination pillar. The coordination pillar hosts the incident management chair that leads the response. Under the IMS2, we also have the surveillance pillar, the case management pillar, laboratory pillar, environmental health, including dead body management and WASH, the IPC pillar, the psychosocial pillar, logistics, and that the RISCOM and community engagement, the RCCE pillar. So these are the 9 strategic pillars that were activated when the incident management system was activated. Next slide, please. But we only look at a few of them to point out some of the work that was being done. So under coordination period, what we did was that we developed the IAP, the incident action plan. That incident action plan was what guided the response, or is still guiding the response. The previous slide, please.
I thought we also lost Dr. Solomon. There is a lot of technical and internet issues. We apologize for this inconvenience. We will wait for 1 minute and then we will go to our next presenter, Dr. And if Dr. Solomon is here, we will okay. I think we lost Dr. Solomon, and then we will go to the our next speaker, Dr. Najla. Dr. Muhtasim, please share the screen.
Screen for Nigla or what?
Yeah, for Najla. And we extend our thanks to Dr. Solomon for his efforts despite the internet connections error. And next, we move to the host country of this webinar, and it is my pleasure to hand over to Naila Ahmed from Sudan FETP. Naila, please proceed. After Dr. Muttasim, share the screen.
في شير سكرين عملوا شير اوت.
Okay.
كلنا يلا استغلت
Dr.
سلطاتي.
Dr. Naila.
تفضل دكتور.
Dr. Naila, are you there?
Hello?
Yeah. Go ahead, Dr. Naila, please. You will have just 25 minutes, so you can go
Okay.
through the presentation.
Okay, hello everyone. My name is Nikla Ahmed El Bashir. I'm public health officer. I'm from Al Gadarif State. I have hold a baccalaureate degree in public health and a master degree in epidemiology. Currently, I'm working as a logistic vaccine officer in IRC. Today, I will speak about Mpox in Gadarif State 2022. Okay, let us start. Dr. Manguri. Hello.
انا مشيت معاك السلايد الثاني بس قلت انتهي ولا نكست؟
أنا السلايد الأولى أوكي طيب. Monkeypox is an infectious disease that can cause painful rash in large lymph nodes, fever, headache, muscle ache, pain, back pain, and low of energy. Most people fully recover, but some get very sick. On 23 July 2022, the World Health Organization announced Mpox as a global health emergency. In Sudan, Sudan reported 375 suspected case of monkeypox nationally in 2022. Those are through the 18 confirmed cases and one death case. The CFR of the cases was 5.5%. The first case of Mpox was reported in Sudan in a 16 years old boy from West Darfur. Go next. Next. Doctor. Hello.
Also lost Dr. Manguri. I will try to share
Okay,
the
let me
screen
try
from my
to share
phone.
ده
from my
معاكم
side.
وجهوني يعني خلاص ممكن ترفعوا
I said next slide.
Please put the screen on presentation mode, please, Doctor.
problem statement.
Okay. Days later, in September, the Federal Ministry of Health Sudan announced the discovery of additional 6 cases, including one in Khartoum state. The new cases involved different states within the country. The surveillance system in Gadarif state detect Mpox through the adapted case definition and reporting channels. Next.
تفضلي.
The next slide. Okay. Here I'm going to introduce information about Gadarif State. Gadarif State is in the east of Sudan and borders Ethiopia. in the east, Gezira State in the west, Sinnar State in the south, Khartoum in the north state, and Kassala in the northwest, and Kassala in the north. The population of Gaddafi state is 2.5 million people with an annual growth of about 5%. The average household size is 5.5 people. The total area of the state is 75 and 263 square kilometer. The state is divided into 12 localities and 21 administration units. Next. Next slide.
next slide refugees.
Yeah,
اتفضل.
refugees.
طيب ممكن تقري من هنا مباشرة.
Okay, as a result of the conflict in Ethiopia is Tigray region, 15,965 Ethiopian refugees have entered eastern Sudan since November 2020. Out of them, 23,617 have been settled in Alternate, and 973 in Umrakuba. All those are set. This data refer to the year 2020. Next slide.
Yes, next map of South of Sudan.
Yeah.
Map of Sudan.
Map not appear to me, but here the map is showing the location of Gaddafi state in the Sudan by the locations. Here in the next map, we have Gaddafi state by the borders and the localities of the Gaddafi, 12 localities of the Gaddafi. Next slide.
Epidemiological.
Yeah. On 15 September 2022, 3 suspected cases of Mpox were reported from Al Mafaza locality, attended by refugees camp. All the reported cases were with fever and skin rash. Gaddafi MH, in coordination with WHO and other sectors, implement an investigation. Then the cases transmitted from Umrakuba from Atenedba to Umrakuba camp in Al-Gallabat East and other localities. The total suspected cases of Mpox in 2022 were 242 cases.
Hello, sorry, your slides are not moving. I don't know if it is just me, but I cannot see the slide you're talking about.
Okay. Could you please stop your screen, Dr. Muntasi? I will share my screen.
I didn't see the map either.
Okay.
I'm stopping.
So I will share my screen. I will use my mobile phone. So my apologies, because we have a lot of internet and also electricity issue in Sudan right now. I will share your presentation, Dr. Naila, through my phone. And we are apologize for this inconvenience again. When my screen is appear, please tell me, because I couldn't be able to see the. Yeah. Could you see my screen?
Yeah, can start.
Is it clear now?
Yeah, go on.
Are you here?
No, next. And next. Yeah, yeah. Yeah, yes. Okay, we are
Okay,
speaking
continue.
about the epidemiological situation in Gaddafi state in 2022. On September 15, three suspected cases were reported from Al Mafaza locality, from Atenedba refugees camp. All the reported cases were fever and skin rash symptoms. Gaddafi MOH with coordination of with WHO and other sectors implementing an investigation for to follow the cases. The cases transmitted from Tonedba to Umrakuba camp and to other localities. The total suspected cases in 2022 were 242 cases, and the confirmed cases were 3. The cases were increased daily in the clinics in the camp. Samples were collected. Perhaps maybe 8 samples. The case definition of the Mpox. The suspected case definition has 3 stages: the suspected and the probable and the confirmed case. The suspected case, a person in any age presenting in a monkeypox an unexpected acute rush, and one or more of the following signs or symptoms. This is due to 15 March 2022. The symptoms are headache, acute onset of fever, malaria, pain, back pain, anesthesia, lymphadenopathy. Next, lymphadenopathy after. Or also the suspected cases mean for which of the following common causes of acute rush do not explain the clinical features. Those are many diseases that have the same symptoms. Next slide. The probable case is a person meeting the case definition of the suspected case and one or more of the following. Has an epidemiological link, face-to-face contact or direct physical contact, or as using contaminated materials or so, or reported travel to monkeypox endemic area or country. Also has had multiple sexual partner in 21 days before the symptom of onset, or is hospitalized due to the illness. Next. The confirmed case is a case meeting the definition of either suspected or probable case and is laboratory confirmed for monkeypox virus by detection of unique sequences of viral DNA either by real-time polymers chain reaction, this is PCR, and or sequences. Here is a table showing the distribution of the Mpox by localities. We have number one, Mafaza locality, Here, most of the cases are in the camp, Atonetba camp. The cases, the suspected cases was 206 case. The confirmed was 3. The sample taken was 25, and the delay of result were 2. The first case was detected in 15, 9, 20, or 15 September 2022. Then Al-Galabat East, most of the cases are in Umrakuba locality. The cases, the suspected cases were 28. The samples taken were 11, and delay result were 2. وسط القضارف locality, وسط القضارف locality, the cases, the suspected were 4 case. The sample taken for 3, and the delay, no delay. The first case was in 22 September. القضارف, I mean بلدية القضارف, the suspected cases were 3, and the samples were 3 also. Here is a mistake. The last one, the last locality is وسط west east وسط الجلابات الغربية. The suspected case is 1, and the sample taken was 1. Also, the case detected in 10 October or 6 October. Next. The common symptoms of the cases were most of the cases sign and symptoms were mild fever and rash, which were appeared in all confirmed cases. Additionally, one patient was expressed enlargement of a lymph node, and eventually all samples, here I mean the 3 samples that from Tonetba camp were diagnosed at the federal lab by VRC and test of confirmation of Mpox. Next. Here is the investigation of the cases in 2022. Mainly, we investigate all the cases, but we take the first 3 cases, or the first reported 3 cases, to summarize them. During the investigation of the first 3 cases, there is no obvious epidemiological link between them. The first case was only the mother went out of Al-Gadarif, went out of the camp from Al-Tunedba, traveled to Al-Gadarif for 1 day and returned. The child, after her return by 1 day, the child sign and symptoms appear. The second case, the onset of the sign and symptom of the second case was in 16 September. The third case, the onset of the sign and symptoms appear earlier on 14 September, and the registration of the cases was completed on 21 September. Next. Okay, the investigation of the cases in Gadarif, all the confirmed cases were infant. The 3 cases were 10 and 8 and 12 months. Here, the crowded of the environment in the camp affected the transmission. This is be clear for the in the Tuneba camp and Umrakuba camp also. Next. Here are samples of the cases. Most of the cases are children. They are in age between 2 to 5 age group. Next slide. Here is the distribution of the suspected cases by the localities. For the localities, we see that most of the cases are in Atonetba locality, in Al-Mafaza locality, mainly in Atonetba camp. The next locality that reported cases is East Al-Galabat, also in Umrakuba camp. Then we have وسط القضارف and West Galabat. All these localities are reported cases, but most of the cases are in the camps, in Tonetba camp and Umrakuba camp. Next. Here is the distribution of the Mpox cases by age group. The first age group was from 0 to 2 years or 1.9 years. The cases were 31. And the age group number 2, from 2 years to 5. Here is the most of the cases are centered here in this age group. Then the other age group, 5 to 14 or 5 to 14.9 age, here are the most of the cases after the age group number 2. In this outbreak, most of the cases are centered in the children. In the adults are only 6 cases. We have only 6 cases. Next. The distribution of Mpox here by the gender, the male and female. Female reported 57%, and the male reported for 43% of the cases. Next. Here's the distribution of the cases among the refugees and the host community. We see that most of the cases are reported in the refugees camp. Maybe this is due to the situation of the refugees, and services maybe there are risk factors that make the disease distributed in the camps more than in the host community. Next slide. Here's the distribution of the cases by EB weeks. The case started in the week 36 and graduate reporting the cases till in the week number 38, 14 cases, and in the week number 39, here is the peak of the epidemic care. The cases are 191 cases, and then the cases decrease in the week number 40. Next. We have comparison here between the camps or the cases in the camps by the gender and by the age group. By the gender, we see that the cases in Atonetba camp are more than in Umrakuba camp. And also the next slide, by age group, more than 5 or less than 5. Also in Atonetba camp are more than Umrakuba camp. Next. The response activities. Here, after the reporting of the cases, Gadarif MYH is leading coordination and implementing of the activities in the localities that affected by the Mpox. Meeting with CORE and other partner was conducted to discuss the situation. Here, this meeting was in Atonetba camp. A swab samples was taken for 3 suspected cases and sent to national lab. This is from التنيطبة and Umrakuba camp. Airtime for locality surveillance team. Here, the RR teams are trained to and started to do their best to involve the outbreak. Conducting active surveillance and household investigation for case finding through volunteer and health worker in Atanetba and Umrakuba camps and the host community. Supporting delivery of integrated BHC services, including treatment of cases, follow-up for all cases was implemented regularly until recovered. Next. Follow-up the contact person in the camps and the host community during the active case finding. Capacity building in the case management and lab sampling. Also, capacity building for health promotion directorates in target localities and community volunteer in the camps. Awareness sessions are implemented in the refugees camps and in the community by the local language for the Tigray and for the host community by their local language. Meeting with the passport and customs department in Basunda and in Al-Gallabat. Al-Gallabat here is Al-Gallabat in Basunda locality, the village that cross-border area of the Sudan and Ethiopia. Activate reporting from the border areas with Ethiopia. Next. Here is intervenes of the localities or health authorities to reduce and control the spread of Mpox. Starting with the first meeting in the camp of Tanedba, the health authority in the locality and the MOH decided that the camp must be closed for 1 month and awareness campaign was conducted in the camp and the host community. Rapid response teams were trained, hygiene items for refugees community were distributed, and medication was provided for healthcare centers. Next. Also, we have joint missions or joint activities with Animal Resources Department. Joint team from MOH and Animal Resource Department were implementing activities for acting or finding the animals that has related to the Mpox outbreak, especially or starting with the Tanedba camp, and they have implemented an activity to control the rats. Next. Here, this picture is showing the meeting in Atanedba, first meeting in Atanedba between all the sectors with the coordination of the MOH and FETP core and Al-Mafaza locality and others. Here, the joint team is implementing the investigation of the cases. Also, the other slide, the same, the joint team from Al-Mafaza locality and FETP and the WHO and cadres of the clinics in At-Tanedba camp clinics. Also here is joy emission. Here is a sampling from Tonedba camp and Rakoba. Also the camps from Rakoba. This is my reference, and thank you.
Thank you very much, Najla, for sharing this invaluable experience. And now let's hear from Uganda, a nation with actually significant experience in managing infectious disease outbreak. So please welcome with me Dr. Richard Migishi from Uganda FETP. The screen is yours, Dr. Richards, and could you manage to share your screen, or I would share for you?
Can you confirm whether you can see my screen and hear me as well?
Okay, let's start my screen. Yeah, your screen is
clear.
Okay, let me just say hi everyone, and I just turn off my video to spare everyone's internet. I'm Richard Migisha, and I'm the field coordinator for the Advanced Field Epidemiology Training Program for Uganda under the Uganda National Institute of Public Health, UNIPH. And I'm happy to share with you the success story for Uganda's Mpox outbreak control. Okay, this is the overview of the presentation. We will go over the situation of the outbreak in Uganda, the successes by pillars, and the best practices along with also cross-cutting enablers. Of course, this came with some challenge. Yes, please.
The slides are not moving.
Oh. Then are they moving?
Yeah, now we can see the slide that you were talking about.
Okay. All right. Can you see the next slide also, number 3?
Yeah, it is not in the presentation mode. We can see
I think then let me see, can you share from your end then, because I don't know how to solve that technological hiccup.
Okay, I will share your screen from my side.
Okay, let me unshare. Sorry about that. So as is sharing, I think I can be speaking through. In Uganda, we had the first case of Mpox in July of last year, late July. So this has been a protracted outbreak largely, and we are dealing mainly with the grade 1B of the Mpox virus. I can't see my slides. Are you able to project those? Okay. Okay, go to slide number 3. Okay, so cumulatively, we have had 8,355 total cases, and these are all confirmed. I do not have suspected cases in this presentation. We had 51 cumulative deaths, and that makes a case fatality rate of 0.6%. to notice that 83% of the districts, more than 2/3 were affected. So each, they reported at least one confirmed case of Mpox each. So this was a widespread outbreak. But to note from that epi curve is that we have managed to flatten the curve, as you can see towards the end, and until now, this curve is flat, meaning that we are not registering new cases. Next slide, please. Regarding geographical distribution, all regions in the country were affected, except the northeastern region of Karamoja. And this has to do with the distribution of the drivers of this outbreak in Uganda. The outbreak was largely concentrated in the cities and the central business districts, which are shown in dark blue color. Because of the exposures that I will share with you in the coming slides. Next. Regarding occupation, we noted that most of the cases were actually sex workers, and that explains why this was predominant in the cities and the central business districts. And in this tree map, we see that they composed about 30% of the total cases. And so to say that these sex workers were actually key population for Mpox spread, and that's why they were also targeted for vaccination. Next. The role of the fellowship program, the FETP, our role were under surveillance, and many were tasked with the case investigations and the case finding. So in these photos, we see the fellows of the FETP doing case investigations in the first photo, and the second photo, active case search, reviewing medical records. Next. So the information gathered from the case investigations was then used to update the surveillance dashboard. And this really, these digital platforms enabled timely decision making, because the fellows and the fellowship program generally would present weekly in the surveillance meetings, and this is a screenshot of the database that we were using, and the fellows are the ones who were managing this database and updating and analyzing all those data. Next. So what were some of the successes or breakthroughs within the surveillance pillar? First of all, we noted that the use of the digital tools, especially EIDSR and Go data, these were rolled out in outbreak districts, and it enabled timely reporting and also timely contact tracing. There was also a training of about 5,000 village health teams. These are equivalent of the community healthcare workers, and that enabled the community reporting, making surveillance work easier. We also noted that the majority of the cases, about 72%, were actually investigated within 48 hours. And this allowed timely characterization of the disease spectrum and also transmission drivers, which led to, generating evidence-based interventions, such as informing vaccination of the high-risk groups timely. And also the timely contact tracing actually reduced transmission in the communities. Next slide. So because this was a nationwide outbreak, the National Rapid Response Teams, where the fellows, our fellows are part of, they really had to do mentorships of the regional surveillance teams and the district teams, as well as the laboratory teams, because we needed to decentralize this response. And in this photo, that is the team of the national responders mentoring the regional teams. Next. So one of the successes in the lab pillar was enhancing the laboratory capacity, and this mainly was done through decentralizing the testing and also trainings. In this map, it shows the several testing sites and hubs across the country. The different colors represent the different rollout times, because this was not done in one go, but we have now about 100 laboratory hubs that are functional for Mpox testing, and about 1,200 lab personnel were trained in biosafety and testing. And majority of these were actually leveraged on virtual platforms to do this, which was a good practice. But also the mobile laboratories, especially in remote and hard to reach districts. And this enabled the turnaround time to drop from 10 days to about 4 days or less. Next. So one of the game changers for this response was actually introduction of the Mpox vaccines. In this EPICAV, we see following introduction and vaccination is at around April, we see about approximately 90% decline in incident cases. So far, about 258,000 doses have been received, and we are targeting the high-risk groups, the sex workers, long-distance truck drivers, the fisher folks, men who have sex with men, and drug users. And the utilization rate for the vaccine currently stands at about 84%. Next slide, please. So with regard to risk communication and community engagement, RCCE, some of the successes were able to reach about 70 to 80% of the high-risk communities, and the community leaders, traditional, the local leaders, they were engaged early in mobilizing the communities, and there were also real-time rumor tracking systems that enabled this to move on. Next. In this photo, we see that the president, during the New Year's message, actually, he talked about Mpox, and at this point, we are at the peak of the outbreak. So this was very helpful in, improving the political will, first of all, but also the awareness. The country listens to the president, so the whole country now received the Mpox message, and this really helped us to even do our surveillance activities and the Mpox control. So it was also another game changer in the response. Next. So with regard to case management, a lot of health workers were trained, about 2,000 on IPC and clinical care. But also we expanded the isolation units. Initially we had 2, but as the outbreak grew, we expanded to all the regions. So 16 treatment units, but also we are overwhelmed. Not all cases could be admitted. So we resorted to home-based care for non-severe cases, and this one really helped to reduce the hospital burden and any other health care acquired infections that could arise from this. Next. The routine care, the services were not really interrupted. We maintained the routine care in more than 85% of the health facilities. And also Mpox screening now has been integrated into routine care in the outpatient department clinics, HIV clinics, and also maternal and child health clinics. It's now routinely being screened. Next. So what made the response work? First of all, Uganda has been a hub of so many outbreaks, ranging from Ebola, COVID-19. So we leveraged on this experience. But also, most of our outbreaks, 90% has not in nature, and has been that One Health coordination and building the One Health, platform. But also, we noted the rapid scaling of digital tools really helped us to get timely data and timely analysis for timely decision making. We have a strong incident management system, so that coordination was also very helpful. And the clear leadership, of course, the political will and the multi-partner engagement were also critical, as well as the data-driven interventions. All our interventions in the response were really guided by, data. We went in to study very fast and came up with evidence. And based on evidence, then we would say this is the next step. Next. So lessons for the future, we see that digital surveillance actually saves time, and the local leaders increase community trust. It was really helpful when we engaged them. And also, rapid training models that are scalable. Like here, we leveraged on virtual platforms. They helped us to reach almost the whole country in a short time. And also mentorship is a good strategy for sustainable workforce development. Next. Cross-cutting enablers generally can point to two strong ones: political will and the donor coordination. And also we have a strong national epidemiology and laboratory workforce that was on top of all this. Next. What the other FETPs should probably take away is that rapid action matters. I think this is the goal of field epidemiology, to really move in so fast and work with what you have. This was really what helped us investigating those new clusters emerging and re-emerging, and getting drivers to get the evidence out of that. But also, let's use the outbreaks as knowledge capital, because we realize our experience in Ebola, COVID-19, and all these other outbreaks have helped to build resilience in terms of outbreak response. But also, community engagement is very vital. Otherwise, we can't fight these diseases when the community is not convinced. Next. These are some of the key challenges, but cross-cutting is, although we had the One Health approach, it wasn't really that fully embraced. Remember, Mpox is a zoonotic disease, but also there were cross-border challenges. Then the funding was limited. This was a very large outbreak, and at the point when the donor funding is dwindling. So, and we had also inadequate surge teams, especially the laboratory. We had to increase the laboratory capacity, and the surge teams needed to go to those districts. This was a new disease, new diagnostics. And also limited availability of testing kits and reagents, especially for differential testing. Because the key question was, if it is not Mpox, what is it? We needed to provide those answers. But happy that as the outbreak unfolded, this testing capacity also increased, and we were able to match that demand. Also, there was some stigma associated, with isolation. There was resistance. Because of the previous COVID-19 experiences, people didn't have good, some had bad experiences in isolation units. So all these also came back to hit at us, the failures of the past. But again, with the community engagement, that improved. And the case management, we noted there was delayed integration of care, especially Mpox HIV care. Yet, you know, most people, HIV and Mpox, they share similar roots. And also the Mpox cases had more severe disease. But also misdiagnoses were common, largely attributed to low index of suspicion among clinicians. Cross-cutting was the concurrent outbreaks. We had an Ebola outbreak early this year. We had Crimean Congo hemorrhagic fever. So these hemorrhagic fever outbreaks really competed for resources, and we had to use the integrated outbreak management model to make sure that all of these are controlled concurrently. Yeah, it was a good challenge. Next. Yeah, other cross-cutting challenges generally, they are the stockouts, the cross-border control gaps, and resource shortages in summary. But these were overcome through, you know, mobile labs, a rollout, improving the risk communication and community engagement, and multi-partner coordination. Next slide. Yeah, happy to welcome your questions, if any. And next. I really acknowledge the following institutions. Thank you so much, moderator, and everyone for listening.
Thank you very much, Dr. Richard. And actually, I am amazed by this experience and by the knowledge you sharing and how well you managed or deal with these outbreaks. Actually, I've read a lot of about your experience and how well you are doing and with your team. And before we move to our expert or national or expert commentator, I would like to Dr. Muhtasim to present his screen, but Muhtasim will have about just 7 minutes. So please share your screen or I will share it for you. Dr. Muhtasim?
I share now.
No, I will share your screen. Don't worry. I will share your screen, Dr. Muhtasim.
Yes, you can share.
Could you see my screen?
Yes. ماشي كويس.
Okay, go ahead now, Dr. Muhtasim. You will have 7 minutes to present your.
Hello, my name is Martin.
Dr. Muhtasim?
Hear
Hello?
me now?
Yeah, go ahead. Hello?
My name is Muhtasim Mustafa Manguri. I work at National Public Health Laboratory Sudan, head of Department of Surveillance. I have good experience for outbreak investigation, more than 100 outbreaks. From this outbreak, 2005, outbreak of human monkeypox in Bantu, previous South Sudan. Our yes, uh, successful story of challenge. This investigation highlight significant success story, rapid detection, and collaborative response in challenge or conflict environment. The challenge in late 2005, Unity State, previous South Sudan, was emerging from long civil war with fragile health infrastructure. An outbreak with smallpox-like rash was selected sub-Saharan savanna region. Unexpected ecology for monkeypox, which typically found in forests. The research story rapid collaboration. The initial alert came from MSF France in Antio. Seamless collaboration was established between South Sudan Federal Minister of Health, the State, World Health Organization, IMRU, and headquarter and Sudan office, and UN team overcame significant logistical constraints to conduct the retrospective investigation in January 2006. Successfully investigation methodology. The joint team provide multi-clearance scale with scope of the surveillance in the clinical laboratory surveillance established active and passive case finding across village bordering wetland area. Uh, uh, about 17 village. Case definition category based into suspected, probable, and confirmed case. Uh, uh, Based on clinical criteria, epidemiology, uh, laboratory confirmation, international collaboration allow example to treatment, CDC, USA, and institute, Brazil, France for molecular biology, culture, serology, IgG, IgM, ELISA testing. Because that time our lab have an infrastructure for confirmation this outbreak. Back. Next, ثلاثة. Epidemiological find field investigation receive critical characteristics of the outbreak. Case definition in September, December 2005, a total of 49 total investigation lead to classified 19 monkeypox cases, 10 laboratory probable. Demographic most affected were young people less than 20 years old. Uh, Transmission dynamic human to human transmission was frequent up to 5 generations because uh, no direct contact wild animals was worked by observation. The type of point of thought etymology evidence strongly just point for pattern of traditional killer was Miller two structure was I uh, tried to have identify spread of virus among different nation group during station use extraction or treatment. ده المعالج البلدي clinical virological type and planning exciting some outcome clinical outcome virological surprise outcome yes clinical outcome despite the outbreak size هو zero لحسن الحظ انه ما في وفيات symptoms were typically fever hypotonia physical prolonged كونجو باسين كلاد طبعا نسبة اللي مات عنده عالية significant. Congo-based class is usually associated with higher mortality and in Sudan, low mortality unit of severe uh, in Sadonna, not rainfall. Environmental was ground discovery. Next, conclusion. The Sudan 2005 experienced quite little lesson for global monkeypox response. A new ecological uh, mix. The investigation included that monkeypox should be considered stick to the wetland savanna area of Unity State, expanding our understanding of the wild psychology beyond rainforest. إنه المناخ culture context matter. Identify the role of traditional healing acting was correct to understand mission dynamic. ال- 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 ولا شنو المعالجين البلديين برضه لازم نغيرها. The pile of joint the successfully rise of the unusual outbreak was possible through strong partnership between national authorities, Sudan Ministry of Health, and international agency WHO and CDC, provide things that effective and achieve even limited post-conflict setting. Reference and human outbreak is by novel virus long Congo vaccine glad Sudan 2005 one of a member of the culture, genetic and ecology preserved monkeypox outbreak South Sudan 2005 is also I'm a member of this. Thank you. شكرا جزيلا.
Okay, thank you very much, Dr. Muhtasim. I'm audible. Hello, I'm audible.
Yes, yes, we hear you, Muhammad.
Okay, thank you very much, Dr. Muhtasim, and all presenter. And now to synthesize this learning and provide a broader regional perspective, we are very happy to have today with us Dr. Priol, environmental and also public health expert. And we now turn the floor to our expert commentator, Dr. Briels. I'm very happy that you with us today, and we apologize for all this inconvenience due to connections and electricity. And the floor is yours. And thank you for your patience.
Thank you, everybody. I will just turn on the camera briefly so that you see me before I turn it off to spare your network, your bandwidth. So my name is Jaba Berio Guatancho. I'm happy to be here. It's really an honor to be part of you and to listen from all of you who have presented. It was really amazing and good insight. Thank you all for the hard work as well on the field, or that you have been able to do to support your various countries. It is very important that you actually went out of your way to ensure that you manage this outbreak as much as you can. So kudos to all of you. It's a commendable effort which I applaud. Now, before I give general comments, I will just let me turn off my camera. So I hope I'm audible, by the way. Okay. So I talk very fast, so if for some reason I'm fast, just interrupt me and I will slow down. I'm doing my best to slow down right now. So in case I'm fast, please just let me know. So before I just give a general comments on coordination and response generally for the Mpox or any other outbreak, I just wanted to lay some emphasis on some. By the way, I applaud Uganda. I was jotting down some questions to ask, and when I jot down a question, the next slide comes with a response to my question. So I end up canceling the question that I was initially going to ask. So I applaud that, and the fact that you also leveraged on a previous outbreaks to be able to improve your response, then it's a good thing. It's a really good thing. So I would just say, unfortunately, we didn't have Liberia presenting, which we missed due to networks. But maybe for Sudan, when Nagla presented, I had some few. I was confused a bit at some point. You see, I noticed that you had 300 at the beginning of your slide. You had 375 suspected cases and then 18 confirmed. I want to believe that and then in 2022 you mentioned 242 cases and 3 confirmed. I want to believe that that gap is a little too wide in terms of the suspected and confirmed. So I mean, it's good to understand exactly what happened. Were there testing issues? Were there any difficulties in you trying to get to the field for sample collection? Was the case definition not clear enough? So those are the things that also you need to look at when you're doing that. Kudos again to Uganda. I like the fact that you presented just the confirmed cases. A lot of the time, once you do the investigation or verification and you discover that it is not Mpox, it is what's the word? It just kept out of my mind, but it is tossed out. The word just escaped my mind. It is tossed out. So you present it's just the confirmed cases, which I think is ideal. It helps to tell the audience exactly what is going on and where and how many people are involved, and it steers the response. But when you have suspected cases mixed in with confirmed cases, it gets people very much confused. So I think that Uganda did a good job too in doing that. For Sudan as well, you also mentioned a meeting with partners. That is a good way to start. It's important to have that meeting with partners, that coordination meeting with partners, to understand exactly what they are doing in line with your response plan. I didn't hear much about any response plan, any national response plan, because the partners are supposed to fit into your response plan. So the country or the MOH or the institution concerned will, after the declaration, you will now establish a response plan. And then once you bring in the partners, they will now fit into your response plan, see how to maybe have resource mobilization where they can support based on their mandate. Okay. I also did not hear much about an IMS. I also did not hear much about an IMS structure that was set also in Sudan. Maybe it was, I don't know, but I didn't hear much about it. It is very important. That is like the first thing that should be done once an outbreak is declared. An IMS should be set. Coordination steers the response. Where there's no coordination, the response will stall. The response will stall. So there's that also that you need to, maybe it was mentioned, but I don't know. Also, I did not hear anything about, still on Sudan, I did not still hear anything about a cross-border collaboration. The state, I think you call it a state, that was affected is bordering Ethiopia. So I didn't hear much about cross-border collaboration, whether there were any meetings or anything of that sort, to be able to ensure that what you're talking to the other, the country on the other side, just to avoid any further transmission of the disease across the borders. So I think that is also important. And also isolation units. I didn't hear much on case management as well on that. Maybe it is you have it, but I really didn't get much on that. But on your case, you mentioned on case investigation, again, kudos on the One Health approach that you mentioned, working with the animal health department. It is very important in order to control, to have this response under control. Same thing too with Uganda. I applaud that. Also for capacity building for both teams, Uganda and Sudan. I like that. And the fact that there was community engagement. You use community health volunteers and healthcare workers to support in the response. If you don't use them, then definitely your response will stop. But the fact that you were able to use them, it was a plus. And for Sudan, the fact that you were able to do your sensitization or awareness sessions in the local language, it is very important. You are encouraging inclusivity, because if you just do it in whichever way, at the end of the day, the people that you are targeting, they don't get your message, they don't hear your message, and they are lost, and the transmission will continue. So I definitely applaud that. I will not go into so many because I had some questions. I don't think we have much time, so I will just go now to the general comments. Also, one thing again for Uganda, the digital tools that you use, that is perfect. Paper-based tools, it does not inform people real time, and it will stall decision making. But for using the digital tools, it informs real time and encourage proper decision making. A lot of the time when you're doing response, it is on the spot. What is available? What do we have? We need to take a decision now. So when you have that real time information, it drives a better decision. But when you don't have that real-time information, you are just making decisions off the top of your head, which might fail. Okay, so I like the fact that you were able to use that the digital tools. And one thing I didn't see also from any of the groups was information products. I didn't hear much about that. The CITREPs and all of that. It is good to, if we're producing good. I think Uganda, I've seen some of your CITREPs. Sudan, I've not worked with Sudan, honestly, so I don't know, but I didn't hear it in most of the presentations. So that is the point that we need to look at to ensure that however the response is going, we're able to communicate it out there to the partners, to all the stakeholders that are involved in the response. Okay, so now to my general comment. I will try not to be long. Just to summarize what I've said. So across Africa generally, I just put down a few points, okay? So just permit me look through the points so I can speak to them as fast as I can. Across Africa, based on the interaction review that we had for the continental Mpox response, it showed that outbreaks are controlled faster when coordination is clear, which is what I mentioned earlier. That means this rapid activation of a functional IMS. A lot of the time, you activate your IMS, and sometimes it is not functional. People are not available. They are not dedicated in the response. So all of this, it impacts the response negatively. So the IMS should be functional, of course, led by the institution, the national institution, public health institution, with clear spelled out roles and regular meetings or briefings with partners in order for them to align their own plans with the national plan, which is what I mentioned earlier. So definitely the country will develop your national plan, and the partners will be able to fit in. So because many of the challenges identified most of the time include maybe fragmented reporting, slow field operations, and inconsistent partner action. These problems can be addressed with a strong coordination. Okay, so I think this is important. So for any future outbreaks, early activation of a coordination mechanism or the IMS is a starting point. So the next also, which I believe most of you are very good at, is early detection and investigation. This remains the heart of outbreak control. Any weakness in contact tracing, community-based surveillance, data quality is usually a challenge in many of the countries. But if we strengthen this, especially using the digital tools you mentioned, EIDSR, and also conduct rapid field investigations, verifying alerts in real time, and ensuring that data consistency, that there's data consistency, all of this will strengthen the response, and hotspots will easily be identified. There will be cross-border surveillance and early interruption of the transmission of the disease. So I think this is also something that we should take into consideration. The third is integration of the pillars. I like the way Uganda brought out their presentation. It shows that you were working in collaboration. All pillars worked together, not in silos. A lot of the time, in some countries, you see that they're reporting that there's a gap in the link between maybe lab and surveillance or case management or IPC watch or RCCE. But if they work together in an integrated manner, the outbreak they will be interrupted. There'll be early interruption of the outbreak. You see that because they were working together, especially for Uganda, vaccination was able to be given to the right group, the high risk groups. They were able to target the right people, and they were able to interrupt transmission. So I think that it is very important for all pillars to work together. Strong response requires fast sample collection, timely laboratory results, safe and dignified patient care, strong IPC, and all of that. So it requires this continuous, it also requires continuous trust within the community. So that's where RCCE comes in. Okay, so I wanted to mention that it is very important that all pillars need to work together and not in silos. Also, to strengthen coordination on the response, we also have logistics and information systems that must be reliable. Any delay in the supply of medical countermeasures or gaps in sample transportation and limited visibility on stock, all of that will stall the response. So it is important to ensure that logistics is up to standard. Also, to have simple dashboards, real-time CTREBs, I mentioned information products, dashboards, CTREBs, and all of that, and a harmonized database to help in decision making. And I didn't hear much about research either in your presentations. In the first presentation, he mentioned that Liberia, unfortunately, he didn't continue, that that the cases, I don't know if it's Liberia, that the cases were more in adults, but they didn't know why the cases were more identified in adults than looking at the age. So it would be good to ensure that research now comes in. It plays a critical role. It helps countries to generate evidence on transmission patterns, risk factors, clinical outcomes, and the effectiveness of interventions in the real world setting. So I think research is also one strong point that we need to look at. And partner harmonization, I think I mentioned this earlier. The partners work with the public health institution. They are there to support. The public health institution leads, they are there to support. So in order for you to understand what they are doing and for them to also know where to fit in, you need to have that partner harmonization, mapping them to understand what they're doing, where they are, what their mandate and all of that, so that you can all work together collectively for the good of everyone and to have a successful response. I mentioned also on vaccination. Yes, it plays a pivotal role as well. It requires detailed micro planning, a robust cold chain capacity, and a clear strategy for reaching high risk and affected population. However, vaccinations only succeed when the communities trust the process. So you see, I mentioned earlier about the pillars working hand in hand. RCCE needs to be able to work closely with vaccination for the community to be able to accept the vaccines. I think Uganda mentioned that. Kudos to you too on that. Uganda, I mean, I'm really happy with your presentation. Yes, I'm really happy with that presentation. And then also a strong laboratory system. I think Sudan's presentation, you mentioned that they sent the samples to the national lab. I think it is good to encourage decentralization of these labs. When the testing is concentrated only in in national reference laboratories, it delays sample transportation and long turnaround time. It slows down investigation and control measures. So I think it is important to have a strong laboratory system. Mobile labs, I think Uganda mentioned it again, mobile labs can be used. We need to have the approach where the testing is done closer to the community to reduce any bottlenecks and support timely decision making. Okay, so I think the last thing I'm going to talk about is preparedness and surge capacity. This also helps countries to stay ahead of the outbreak. I like the fact that both teams mentioned the use of the deployment of your RRTs, your rapid response teams. It is very important to have trained rapid response teams to pre-position supplies and also have cross-border collaboration. This will allow quick scale up when there's any increase in cases. And at the center of everything, at the community level, it's important to work with the communities, which I believe I heard in most of the presentation. The feedback, participation, and trust determines how effectively cases are reported, isolated, and managed. So I think like in the presentation from Sudan, where there was that big gap in the number of cases, I want to believe maybe it was late reporting or something of that sort, because the gap was extremely wide between epi week 38 and 39. There was a sudden spike in the number of cases for week 39, and then a sudden drop in the number of cases for week 40. So I want to believe that maybe it has to do with reporting or these issues or transportation of samples. Maybe I might be wrong, but I'm just speculating. So I think generally we should ensure that the country is prepared. There's also CIMEX. You can do a lot of simulation exercises to prepare the team in case of any future outbreak. Okay, so I think that is what I can say from all the presentations. I hope I was clear enough. Apologies if I was fast. But thank you so much. These presentations indeed were very insightful, longer than I anticipated, because I mentioned to Mohammed that I was in the training and I stepped out of the training to be part of this webinar. So I think I've abandoned them at the training because I'm currently in Uganda. But thank you so much. Congratulations once again and courage. Thank you.
Thank you very much, Dr. Priel. And actually, I'm very happy that you is with us today. And thank you once again for that critical, high-level segments and insightful comments. And as I said, thank you once very much for being with us today, despite your busy time. And actually, I appreciate that. And due to times, we have just a two or one chances for any questions or comments. So please, before we close the meeting with the field epidemiology or Sudan field epidemiology training program field coordinator, Dr. Sabir. And if anyone have any question, please raise your hand. So Dr. Ahmed, go ahead, please.
Thank you very much, Muhammad, and thanks to the presenters and to the commentator. Actually, my question is to Dr. Mijisha from Uganda. I think it would be very insightful and we can take good lessons and practices from this. If you elaborate more on the mortality, and I see there is a significant case fatality ratio. It's 0.6, I guess. But this is a significant number of cases who died because of the Mpox in Uganda. Can you give more details on the causes of this? Is it the Mpox itself, or there were some other comorbidities, maybe other contextual factors that contributed to this significant number of deaths, or any other insights you can please share with us, and what are the practice and how you mitigate this and improve your practice to reduce the mortality from Mpox. Thank you very much.
Thank
Okay,
you
thank
very much.
you. Should I speak to that or the question should all come in?
Maybe I can just jump in on one little question. I wanted to know if the IMS activation in Uganda, was it done also at district level? Because a lot of the time countries maintain a national level IMST, but the outbreak goes across several districts or counties or whatever appellation. So was it done at district level or county level, or was it just a national IMS? Thank you.
Okay, thank you. I think let me start with the Dr. Hamad. Can you hear me? Just confirm.
Yeah.
Yeah, I wanted to know a little bit of detail about the mortality. Yeah, we actually did a study on this among the case control study among factors associated with the Mpox-related mortality. For all these cases, so we did a case control study. This is not yet out, but is under CDC clearance, the manuscript. But so far, what we found is that the HIV was an independent predictor. So comorbidities played a big role. HIV, and especially those who had advanced HIV disease, whose viral loads were high, these were the people dying. And also comorbidities, like there were some sicklers. So it was largely the multimorbidity, I would say, HIV and other comorbidities, especially those which suppress the immune system. Yeah, there were some with the cancers and all that, cancer. So I think that answers it. Those were the drivers. Otherwise, the numbers are, yes, 51 is a lot, but when you compare the total case burden of 8,000 plus, the case fatality rate of 0.6 is within the expected for that grade 1B. Okay, the IMS system, Dr. Njeba, thank you so much. The IMS system was actually activated across, not only at the district, but also the regions and the district, I mean, not only national. But this was again individualized. We had to see the clusters. Some clusters were big, others were small, and that's how we prioritized really. There were, of course, some challenges. Some districts not as active as whatever as expected because of limited resources. But yes, we rolled out up to the district, especially the districts in the fishing areas and where we had quite a number of cases. Yeah, thank you very much.
Thank you very much, Dr. Migisha and Dr. Ahmed, for these questions. And Hiba, you have the last question from Hiba.
Thank you, Mohammed. Thank you, all presenter. I'm Hiba Abdul Rahim, public health specialist, FETP graduate. I have a comment, not a question. The first case in Sudan in last pandemic started in 2022. Maybe not in East Sudan, in Al Gadari. It was in West Sudan, in West Darfur state, in locality, Kirenic locality. Two cases, two boys, brother, one 16 years and other 12 years. First case in 9 July 2022 and other case in 1 August 2022 in the West Sudan. No relation between cases in West Sudan and East Sudan. and no contact between this and that cases. This is my comment.
Thank
Also,
you.
also cases in IDB's shelter ساحة الأرديباية. Call it ساحة الأرديباية. Thank you.
Thank you very much, Shiba. And as we reach the end of this webinar, I would like to thank all our presenters, Dr. Magisha, Richard Magisha, Field Coordinator of Advanced Field Epidemiology Training Program Uganda, and also Dr. Naila Ahmed from Sudan FETP, and also Dr. Solomons. Unfortunately, we lost him, and definitely to our expert, Dr. Briel. I'm very happy that you will attend these sessions with us and provide us with those insightful knowledge and information. And thank you to every person in the audience, despite the challenges in internet and also electricity. And on behalf of Sudan FETB, this concludes our webinar. Thank you all of them from my side. And as usual, we close with the FETB directors. And today we will have with us Dr. Saber, Sudan FETB coordinator, for adding his last comments on these sessions and also this webinar and close the meeting. Dr. Saber, the floor is yours.
Thank you very much. Really, the work of today is very extraordinary work. I would like to thank the organizer of the forum, the FETB forum, that led by the alumni of Sudan FETB. I also I want to thank our participant from inside and outside Sudan. Special thanks and appreciation for our speakers from Liberia, from Uganda, and also from Sudan. I think the session of today is very extraordinary because the session showcased this special experiences of three countries that dealing with Mpox. So any country has its own experience and its own skills in this matter. Really, we enjoy this session and compare the different interventions led by any country in the region. And I think I want to give a small comment in that about the our speaker from Uganda. When he raised, I think, a special issue that the challenge in case management, that the misdiagnosis, and also Dr. Ahmed speak about the comorbidities. I think these two things are the same. And in here in our context in Sudan, I contributed in the outbreak in 2022, and we faced this issue because that is a huge number in Sudan. That goes to more about 300 cases. I think we faced these issues, and here I want to say that to diagnose the case of Mpox is very hard to diagnose such cases, especially when these cases not dealt with a dermatologist. So we should consider in the future that the cases should be to be seen and investigated by a dermatologist, and that we should take a sample for the laboratory, because the dermatology cases are similar, especially in the camps. Really, I want to expand my special thanks and appreciation for all our audience and our participants. Thank you very much, and really we appreciate that. And big clap for you all. Thank you very much, and see you in next session. Thank you very much.
Thank you very much and goodbye.
Thank you all. Bye bye.
Thank you,
Okay.
everyone. Thank you.